Hello everyone. Today we will discuss about lymphatic drainage of cervix, which is a very important short notes question, and also the knowledge of this is very essential in understanding the cervical carcinoma drainage. The cervix is the lower part of the uterus, and its lymphatic drainage is crucial in understanding the cervical cancer spread. Its rich lymphatic channels drain into multiple pelvic lymph node groups, which guides in staging, prognosis, as well as management. Coming to the anatomy of the cervix is divided into two parts: supravaginal upper portion located above the vaginal fornices and vaginal portion projecting into the vagina. The lymphatic drainage is slightly differ between these regions but maintains a rich subepithelial lymphatic plexus that communicates freely with neighboring pelvic structures, the subepithelial stromal network, the parametrium, and the uterosacral ligaments. Primary lymph node groups. The external iliac lymph nodes, which is the primary route. This is the most common and most important drainage pathway. Lymphatics from lateral cervix course through parametrium and reach the external iliac node located along the external iliac vessels. The first state of metastasis is early cervical carcinoma. Palpable enlargement is rare, but radiologically detectable. Target nodes in lymphadenectomy. Internal iliac nodes, that is hypogastric lymph nodes, drainage from the posterolateral cervix flows into the internal iliac chain. The posterior cervix then travels through parametrium and then through internal iliac nodes. Important for spread of lesions involving the posterior fornix. Recurrence in this group often suggests advanced local disease. Obturator lymph nodes. These are located in obturator fossa, closely related to the obturator nerve and vessels. Deep parametrium resulting in obturator nodes, a common site for microscopic metastasis. Surgeon carefully dissect this area during the radical hysterectomy. Nerve injury here can cause adductor weakness. Sacral lymph nodes. The posterior lymphatic channels drain into the presacral and sacral nodes. Lymphatics from the posterior cervix, uterosacral ligaments, and then passing sacral nodes. Seen in posteriorly invasive cervical cancer, tumors involving the rectovaginal spectrum often shows the spread here. So this is the lymphatic drainage of the uterus and cervix. So the cervix, external iliac, internal iliac, obturator, sacral. These are the four important ones. Okay. Additional lymphatic pathway include common iliac nodes. Lymph from both the internal and external iliac node may converge and drain into common iliac chain. An intermediate stop before para-aortic spread. This represents advanced metastasis. Cervical lymphatics leads to pelvic chains, leads to common iliac and para-aortic nodes around L2. Seen in FIGO stage 3C2 disease. Requires extended field radiotherapy and poor prognosis. Inguinal lymph nodes, which is rare, not a part of direct drainage, is seen only when the tumor extends to the vulva or lower vagina, where inguinal drainage predominates, or after the surgical or iatrogenic disruption of the normal pathway. Patterns of spread: cervical cancer typically spreads in this manner: primary tumor, then paracervical and parametrial lymphatics, pelvic node, external iliac, internal iliac, and obturator, common iliac nodes, para-aortic nodes, and some systemic spread in later stages. Understanding this pattern is essential for staging of FIGO, that is through MRI, CT, or PET-CT, and treatment planning also. Applied anatomy. In radical hysterectomy, surgeons remove parametrial tissue and dissect pelvic lymph nodes. Knowledge of lymphatic pathways prevent accidental nerve or vessel injury. Sentinel lymph node mapping uses blue dye fluorescent markers aimed to identify the first draining nodes to avoid unnecessary extensive lymphadenectomy. Radiotherapy planning: the field borders pelvic and sometimes para-aortic nodes tailored according to lymphatic spread pattern, and nodal involvement is one of the strongest predictors of the disease. Para-aortic metastasis often worsens the survival. So to summarize, the cervix drains into a complex multi-directional lymphatic network that plays a vital role in the spread, staging, and treatment of cervical cancer. They arise from cervical stroma, parametrium, and drain primarily into the external iliac, internal iliac, obturator, sacral lymph nodes, which forms the initial stations of metastatic spread. Additional pathway extend to common iliac and para-aortic nodes, and the later indicating advanced disease and poorer prognosis. This anatomical knowledge is essential in planning radical hysterectomy, pelvic lymphadenectomy, sentinel lymph node mapping, and radiotherapy fields. Understanding these drainage routes allows clinicians to predict the patterns of spread, ensure accurate staging, and provide optimal therapeutic strategies. I hope you have learned from this presentation. Thank you for watching.